Welcome to the Health Trip Podcast. My name is Jill Foose. I'm a functional medicine and integrative nutrition health coach. I created this podcast to bring you along as we travel down intriguing, science-packed roads, debunking old medical paradigms and perusing new innovative therapies and modalities with the finest functional medicine doctors, practitioners, and like-minded biohackers while living our best life. Enjoy the show. Hi, everyone. Welcome back to another episode on the Health Trip Podcast. You often hear me discuss the importance of building your midlife healthcare team. And one of those team members to consider is a preventive cardiologist. While your GP or internist may be ordering annual labs for you, they are not experts in lipidology. Perhaps you've noticed a change in your cholesterol numbers since going through the menopause transition. Most women will see their cholesterol increase. Did you know that cardiovascular disease is still the leading cause of death among women and men? And that risk increases significantly after menopause. This phase of life brings not only physical and hormonal changes, but also heightened vulnerability to heart disease. In this episode, my guest and I explore how menopause influences heart health and why it's essential for women to be proactive about their cardiovascular wellness. We talk about the hormonal shifts that affect everything from blood pressure to cholesterol. And we also discuss the impact of family history and genetics and what labs and tests are crucial for assessing your risk. We also discuss the ongoing debate over using estrogen as a tool for heart disease prevention. And lastly, we talk about the different signs and symptoms of heart disease for women, the different risk factors for women, and treatment available. My guest today is Dr. Martha Gulati, a preventive cardiologist with a long, impressive list of accolades. To name a few, she's the past president of the American Society for Preventive Cardiology, professor of cardiology at the Smith Heart Institute at Cedars-Sinai in LA, the associate director of the Barbara Streisand Women's Heart Center, and holds the Anita Dam Friedman Endowed Chair in Women's Cardiovascular Medicine and Research. She is the author of the bestseller Saving Women's Hearts, and her exceptional commitment to the study of women and cardiac disease has won her numerous awards and distinctions, including being named by Crain's Chicago Business as one of Chicago's top 40 under 40. She previously served as a co-investigator on the Women's Health Initiative, the WHI study, and has published articles in peer-reviewed publications, including the New England Journal of Medicine, Circulation, and Journal of the American Medical Association, or JAMA. If I continue going on about Dr. Gulati, our time will be up, so let's dig in. A short medical disclaimer before we start. By listening to this podcast, you agree not to use this podcast as medical advice or to make any lifestyle changes to treat any medical condition in yourself or others. Consult your own physician for any medical issues that you may be having. This entire disclaimer also applies to any of my guests on my podcast. So sit back, open your mind, and let's dig into women's heart health during menopause. Welcome to the Health Trip Podcast, Dr. Gulati. I'm so excited to have you here today.
Oh, it's my pleasure to be here with you.
So I follow you on Instagram, and I'm going to give you a little shout out. You were just recently at the White House alongside some other amazing midlife women's health experts and physicians. So tell us a little bit about that, just to give us a little bit of the frosting on the cake here.
Yeah, well, it's a very special moment. We actually started a year ago with the First Lady kicking off this whole initiative related to women's health and the gaps that exist related to women. She started it here at Cedars-Sinai, which is where I work. And we were able to discuss with her where the gaps were in what we know about women's hearts and the barriers that we've had historically about enrolling women into trials. And so we started a year ago, and a year later, I had the opportunity to be with her and give her updates of what we had done, what breakthroughs have happened, but also where we still need to go.
Yeah, that's a great intro into segueing into what I want to talk about today, which is really spotlighting midlife women's unique risk factors, prevention, longevity, strategies to improve our health outcomes as it relates to heart disease. You know, I'm a postmenopausal woman, and I can tell you that there's a lot of conflicting information out there. It's very confusing, and you want to believe your doctor, and then you hear something from another well-known speaker or an expert in the field. And so it just becomes this cycle of confusion and fear mongering for a lot of women. So I think one of the places I want to start is asking you, what are those unique risk factors to women, and also how women can know if what are those symptoms of heart disease for her?
Well, let's take the first part first, like the part about the risk factors, because I think that's one thing that's been really challenging. We use these risk scores in our cardiology world to try to give you what is your risk in the next 10 years of heart disease and what's your long-term risk. But if you look at those risk scores, they just have the traditional risk factors, things that you probably know about and are still super important. We should know our blood pressure. We should know our cholesterol. We should know, if we're diabetic or pre-diabetic or not. We should be able to, now the newer risk scores come out and incorporated both our kidney function and our BMI. And I think those are excellent things to know. But for women, most young women, so any postmenopausal woman or perimenopausal when they're that age, almost all the risk scores will put them as low risk. Our risk scores are so age driven, particularly for women, that we really need to consider more than just the traditional risk factors. And for women, there are a lot of sex specific risk factors. And there's a lot of them. I'm going to just kind of list off a few
Hmm.
off the top of my head because they don't get discussed enough when you go to the doctor. Many doctors remain unaware of this and that they should be asking questions about our menstrual history, for example. We should know if somebody has polycystic ovarian syndrome. That can put them at a higher risk of heart disease. Their age of menarche, whether it's early or late, puts them at a higher risk for heart disease. If they use contraception, particularly if they're smokers, I'm not saying contraception is bad, but oral contraception can be dangerous in younger people that also smoke. And then people that have something called functional hypothalamic amenorrhea, which is where periods stop, often seen in young women who have anorexia and sometimes bulimia. That doesn't often get asked because we're so scared of asking women about that stuff, and yet it's so prevalent. Then we need to ask about their pregnancy history, because there's a pregnancy, I always say, is nature's free stress test. It's identifying women that are at a much higher risk of developing heart disease. This can be things like knowing if you've had a number of miscarriages, if you've had infertility and had to use artificial reproductive therapy, if you've had pregnancy-induced hypertension, sometimes known as preeclampsia, but it can be actually any hypertension, even without preeclampsia, gestational diabetes, preterm birth, or a small for gestational age baby. And all of those should be asked. And then for older women, we should be asking women about premature ovarian insufficiency or premature menopause, because that actually puts women at a higher risk, whether it's natural or whether it's surgical. And we should be talking about, are they using hormone therapy? Are they not? How long have they been on it? All of that can help us better risk stratify women. But I will be honest that even some of my cardiology colleagues will not ask all these questions. And I think it's a barrier to really appreciating the risk for women.
I couldn't agree more. I mean, I've had 5 kids, and I have never been asked by my general practitioner or my internist any of these questions. Now, I see a preventive cardiologist, which is why I have you on today, to make that more aware to my listeners that a preventive cardiologist should be part of our healthcare team, when, especially in the transition of menopause. And you're not easy to find, by the way.
They're not that easy to find. And
Mm,
I think we're growing
mhm.
specialty. Thankfully, it's a really exciting time in prevention, and more younger doctors actually want to do prevention. So that is really exciting. When I came out, people used to ask me, like, what exactly is a preventive cardiologist, and wondered if I was really going to have a career when I kept telling everyone that's what I was going to be. But I think that that's a great time for women. I mean, the earlier the better, but I will say at the perimenopausal stages for women, often that's where they're noticing things are changing, not just physically to their body, weight gain can be one issue at the time, but they start noticing that blood values start changing. They always were told their cholesterol is fine. Suddenly their cholesterol isn't fine. They might have also been told their blood pressure was actually on the lower side and now it's increasing, or even if it's going higher, even if it's still in the normal range, if you were always lower, that should be a clue that something is going on. And I think that that is a great time to start meeting with your, whether it's your family physician, your internist, or considering seeing a preventive cardiologist.
Yeah, this is a time where a lot of women are gaining weight around their midsection. They are feeling more stressed, more anxious. Their sleep is off. They're not feeling as motivated to get to the gym every day, and they're sort of desperate when it comes to nutrition. They aren't sure what to eat anymore either. And I'm definitely going to dive into that with you later on. But as far as going through menopause, we can't ignore the changes of estrogen and all the other hormones in our body. But can you explain estrogen's protective effects as well as maybe the other sex hormones on our cardiovascular health?
I wish I could. I might win a medal if I could. Uh, the truth is, it's very interesting. We certainly know that women, when they're premenopausal, seem to have some amount of protection that men don't have. And that's why even heart disease tends to, not in everyone, but on average, women tend to lag in terms of developing cardiovascular disease by almost a decade compared to men, meaning more women at a certain age will, it's later. Um, it's not true for everybody, but I'm just saying on average. And we know it at least has something to do with estrogen and our hormones, but it's not the only answer. We a lot of people thought when we had this study called the Women's Health Initiative that prior to that, um, a lot of people, I'm so sorry. A lot of people used to tell um, uh, patients that, hormone replacement therapy was the fountain of youth, and that's what we should be giving to everyone, both just to keep them younger, but also reducing risk of heart disease. There was people touting the quote unquote fountain of youth of hormone replacement therapy without any evidence. And we know it's not the full solution because even from that trial, we did not see that giving hormone replacement therapy necessarily reduced cardiovascular events. And I know there's a lot of criticisms of the Women's Health Initiative, but it's still one of the most important studies that's been done on women. And it's also an example of us as women saying, should we take something that hasn't been studied on us? When those medications were being used without real evidence for what people were saying there was benefits for. So it isn't just giving estrogen back, otherwise it would be an easy solution. And then you're right, then women wouldn't have heart disease. But there is definitely something about the hormonal changes. And I mean, there's changes to estrogen, there's changes to progesterone, there's even changes to the testosterone levels. And all of it together probably has a contribution in addition to aging that has a contribution to the changes that we see in the cardiovascular system and to the cardiovascular risk factors as well. But I just want to point out one example where we might have been a little bit fooled. So when you think about blood pressure, most women, when we're born, our blood pressure is low. And as young girls, we're always a bit lower than the young boys in terms of our blood pressure reads. And for boys at puberty, we know that there's something that happens and their blood pressure goes up and continues to increase with age. And it used to be thought that for women, though, or females, that the blood pressure would only start increasing at menopause, like a switch had been turned on. And that is actually not true. We have now some data actually from my colleagues here at Cedars, where they looked at where the blood pressure starts changing. And the blood pressure, again, although we start lower than men, it has a continuous increase as we age. And actually for women, our rate of increase, even though we start at lower, the rate of increase is actually higher than men. And it makes us also question, is the threshold for blood pressure actually appropriate? Like,
Mhm.
should we have the same cutoff as men? We start out lower, we're pretty happy.
Right.
Everyone's telling us, oh, your blood pressure is low. And we're not symptomatic, and really there's no real low unless you have symptoms. Um, but we live with that, and then it starts increasing. And so my question actually about blood pressure is should we have a different threshold? And we need more data. We need to be studying that to figure that out. But we certainly know that women actually have a lot more stroke contribution, and maybe that's because we allow blood pressure to be as high as men. I mean, again, I'm just using that as an example of where we've made assumptions in our medical community, and it's not fully activated just because you're going through menopause.
Yeah. As I was preparing for this podcast, I was reading that the anatomy of a female heart compared to a male heart is different in that we have a thinner vascular system. Can you just speak to that a little bit? Because I sort of was trying to connect the dots between as estrogen was declining and maybe our anatomy was different in terms of our cardiovascular system, that maybe that is why it plays a bigger role and keeps us, well, men also are it's the number one killer for both men and women. But I certainly, in these last few years, have seen more midlife women just die of heart disease out of the blue, seemingly out of the blue. Obviously, there was something going on, but the families are left wondering like what happened. So I'm just wondering, it's around that 50 to 55-year-old mark, and I just got to thinking about the anatomy.
I think there's so many different things between men and women, not that we have full answers yet, specifically related to the heart. We do some work on this, particularly related to the blood vessels and trying to figure out why when women have heart attacks or when women have reduced blood flow to their heart, what we call in our cardiology world ischemia, they might experience angina or chest pain symptoms or other equivalent symptoms. Well, when that occurs, the problem really is that, men tend to have obstructive lesions, meaning they tend to, if you do a cardiac catheterization where we look directly at the vessels, we can see the blockage. We can open that blockage because we've studied that and we've been able to show that we can put in a stent and they can do well and they can stop having symptoms. The problem is for women, we don't often find blockages. They can have blockages in their vessels, but more often than not, they may have non-obstructive coronary disease or small vessel disease, and yet still present just like a man, have the exact same symptoms, have evidence of ischemia, or even have a heart attack, and we don't find an obstructive lesion. So now some of the work that we've done has teased out that, it is the small vessels of the heart that are behaving abnormally under stress and under traditional cardiac risk factors. And if we take those, you know, we can diagnose different things. We can see that it's microvascular disease. It might be vasospasm in the small vessels, and it can be a combination of the two together even. And targeting treatment to that is actually the next frontier. Right now, I think we know we can identify the disease, but the work that we are doing in a study that will have come out in 2025 is a big study called the Warrior Study that is to help us answer what is the ideal medical treatment for people with these non-obstructive coronary disease, but having evidence of ischemia. And it's a study of women. That's actually what we shared with Dr. Biden, was just some of that was coming. We couldn't share the results yet because we don't know the results yet.
Well, that's exciting.
Yeah.
Yeah, very exciting. I want to circle back to symptoms for women because I think this is something that a lot of women are unaware of. Some of the women I know that have recently passed away had jaw pain, they had upper back pain, but didn't think to themselves, and their kids were home, so we know just through that experience what had happened, that they didn't realize the back pain could have been associated with heart disease.
I think this is something that we have done a very poor job at creating health literacy in our community.
Mhm.
And that's true for both men and women, but for women specifically, I think classically the picture of somebody having a heart attack has always been a man. And so we show the symptoms that a man has and a man having it, and that's what we recognize. And most women, if their spouse, if they're married to a man, they would, if if they were having a heart attack, they would probably recognize the symptoms and they would activate, they would call 911, they would insist that their spouse get to the doctor. This must be a heart attack. But for women themselves, even when they're having classic symptoms, we know that women often will not go to the ER, one, either from a misunderstanding of the symptoms, or two, because they've got too much going on and they put their own health second or third or last in the list of their priorities. It is true, though, that the majority of heart attacks, chest pain or chest pressure is the classic symptom. And I don't want anybody who listens to your podcast to do some of the mistakes that we see in the ER, where people actually understand that women might have different symptoms. So when they have crushing chest pain, they're like, this can't be a heart attack because I thought women present differently. If you're having crushing chest pain, please call 911. Please get to the emergency room. Please be evaluated. And really, we've actually done some work, and many others have now. And we've actually showed that 90% of women and 90% of men actually do experience chest pain or chest pressure at the time of having a heart attack. But the difference between women and men is this: chest pain may not be the most important symptom that they're experiencing. May have it, but that isn't the thing that's bothering them. It may be the jaw pain. May be the neck pain. It may be the back pain. It may be what they think is abdominal pain or reflux. It may
Mhm.
be a profound sense of fatigue that they just woke up with and now can't do anything. Not just the fatigue that we get just from being tired, but I mean, truly not being able to do anything, being able to walk up a flight of stairs and then suddenly not being able to do that, or whatever your activity that you could do really comfortably and easily, suddenly not being able to do that. That can be a sign of heart disease or a future heart attack, or maybe there's a blockage already happening at the time. So, we need women to recognize that. There's a really great little video put out. Elizabeth Banks made it with the American Heart Association. I love it. But it shows a woman actually having the symptoms of a heart attack, but her like popping anti-acid pills, thinking it's reflux. She actually says, I don't have time for this. And it was actually her son who Googles all her symptoms. And as she's trying to get him off to school, he hands her the phone and says, according to the Google, you might be having a heart attack, and that's the only thing that makes her call 911. So
Mm.
I think that we really need women to understand, first of all, it's the number one killer of women. And you should, if you're lucky, please get screened for heart disease, because 80% of heart disease is preventable. But if you are having symptoms that we describe that are new and sudden in onset, do not hesitate calling 911. Do not hesitate getting evaluated, because that might just save your life. And for our medical community, one of the things that we really put forth, I chaired the National Chest Pain Guidelines, and we put in the guidelines that one thing we want our medical community to do is stop labeling symptoms, particularly the symptoms of women, as atypical. That word has been used over and over again, and it's always, I've never seen it actually in my life used towards men. It's always
Mhm.
used towards women. And usually when someone is telling me that somebody is having atypical chest pain, unlike the definition, which means just presenting differently, usually what my fellows and trainees are trying to communicate to me is that they don't think it's cardiac. Well, we put very specifically in the chest pain guidelines, do not use the word atypical anymore, because it's
Mm.
harming women. And secondly, if they want to describe chest pain, they should call it cardiac if they think it's cardiac, non-cardiac if they really believe it's non-cardiac, and possibly cardiac if they don't know and need to do additional testing. And so it's not just us educating the lay woman, if you will.
Hmm.
It is us educating our medical community that
Yeah.
still does not fully appreciate the risk of young women
Hmm.
and women.
Very interesting. Very interesting. Um, in men, they say that if a man has erectile dysfunction, that is a sign of heart disease. Is that the same for women in terms of arousal? There's that little molecule called nitric oxide, and what I've read about it in its connection with declining levels of estrogen is that nitric oxide also declines in terms of aging, the menopause transition as a result of estrogen declining. And I wanted to hear what you had to say about the correlation between if women are experiencing less arousal, and that could be connected to blood flow, is that also a sign for them that they might have a risk of heart disease?
I think the answer to that, from my perspective, is we just don't have enough data. Like, that's the hardest thing, and there's so many things for women that create that that affect a woman's sexual arousal,
Yeah.
emotional, physical,
Hmm.
both contribute. And so I don't think it's as easy as the physiologic, do you get an erection or not? There's not something as easy. Um, as that kind of response for a woman. We're much more complicated than that is the truth.
Yes.
And
Yeah.
so I don't think that we can just use that, like if people are reporting that they're not easily sexually aroused anymore, there can be so many things. There can be tired, it can be postmenopausal, it can be hormones, it could be cardiovascular disease. It could be mentally, like they're under a lot of stress right now. And so there's so many things that could contribute to that we just don't have enough data to really say that is that I would use that as a sign. Things that
Mm.
I tend to use as a sign, though, is more than one thing, meaning asking about that is important too, but asking about their physical activity, trying to find out, are they reducing their physical activity um, just because they don't have time? Or, sometimes it's very interesting that sometimes women and men, actually, for that fact, will actually compensate for what's going on in their heart by just reducing their activity. It's hard, they know, and they're protecting themselves. They don't intrinsically know, but they stop doing things because it doesn't feel right. And so they back off on activities, including sexual activity. And so you need to be asking all kinds of questions to really tease it out. And I think it's great for men. Erectile dysfunction truly is a great physiologic sign that really does tell us about the vascular inner workings of them.
Hmm.
But we don't have something quite that easy.
Of course not.
Yes, of course
Right.
not. I
Right.
always say women, we are more complicated, and there's
Hmm.
just and also we're complicated, but we're also not studied. And so
Right.
right now, I'd say we're at really the infancy of understanding women's hearts and really knowing what to do, because for decade after decade, we've left women out of research. We're getting better. In this last decade, we've made some great strides, but
Yep.
there's still many things that are lacking, and still many studies that over enroll men and or under enroll women and leave us with the quandaries. And that's really why we're trying to say, where is the gaps in our research and what do we need to know? And one of the things that you just pointed out is an area that's a gap.
Yeah, absolutely. I want to pivot to screening and assessing one's risk for heart disease. So, when somebody goes to their internist or their family physician, they're probably getting just a standard lipid panel. And you being a lipidologist and an expert in this field, I wanted you to talk about these comprehensive labs that a lot of people are talking about in social media. Um, and this is where a lot of women are learning information. They're not learning it in their doctor's office, they're learning it on social media, they're learning it from their friends. And it's not always the best way to learn, but at least it's bringing awareness to other ways of assessing things. And so, can you talk about some of these advanced tests that you might want to look at in terms of assessing one's risk?
Yeah, I think the most important thing is that women do get a lipid panel and know their lipids, like know if they're not, they just shouldn't be told, oh, they're fine. They should know, is there, what is the value I'm trying to attain here? And the most important one in all your lipid panel, to be honest with you, not to minimize the other parts that you will get, is know your LDL and know what your LDL goals are. If you don't know your LDL or your goal for LDL, you're not being done by right. Because I think that's where it starts. That's where the conversation starts. And so much of atherosclerosis is an ultimate result of your LDL level. And the more that you know, and are whether it's genetic that your LDL is elevated, whether it's your diet and all these crazy diets people go on these days, particularly the keto diet, can particularly raise your LDL if you're doing it the way that I see it being proposed online. And we've actually had people had heart attacks as a result of their elevation in LDL following a keto diet. So know your LDL first and foremost. And
So, what is the goal for the LDL?
for everybody, it's going to be a little bit different. To be honest, it depends on your risk, and that's why you need it to be, tailored and personalized for yourself. It'll be based on your risk score. I will tell you though, if you just randomly find somebody's LDL above 190, there's probably a genetic component to why their LDL is so high. And so if you're one of those people, you should definitely be under the care of a lipid specialist. And just generally, like just a ballpark in general, like ideally we love people's LDL to be under 100, but if you already have cardiovascular disease, then we try to at least aim for your LDL to be under 70 and sometimes lower depending on the individual person.
Yeah.
There is lipid profiles that you can get done called NMR profiles that break it down into particle size, that can give a little bit more information to your physician. I will say that I will say that half of the lipid world likes them and the other half doesn't use them. And so there's a little bit of controversy because when you get those, we right now don't have ways to target, like, so just because say you have a lot of small particles floating around based on a fancy lipid profile, we don't target those numbers. We don't have trials saying target those numbers and we can improve outcomes. And that's why I'm probably in the camp of I don't check it. I don't mind if someone brings it and wants to talk about it, but I generally am not the person who will be following that. One of my colleagues, he loves them. And that's
Hmm.
okay. I think if you use them to communicate risk, they're very helpful. I use them more if we really don't identify any risk, and then I'm trying to find out why is there this family history, or why did this particular person already have a cardiac event? Is there something I can identify that in traditional risks we can't? So the other thing though that people should all get checked once in their lifetime is something called LP little a.
Hmm.
LP little a is a genetic marker. It's really dictated. You get it once, and that's really all you need it done, except for women. Women are so interesting, and but for women during menopause, in that perimenopausal to menopause era, their LP little a can increase. And so there can be
Right.
women that are borderline or in the intermediate range of an LP little a. Those are the ones that I might check it again. I might not check a completely normal one. It's probably going to go up, but it'll probably just stay in the normal range. But it's more those people in between that might bump up to a higher level. And that we do know happens at menopausal time. So it's important to be checked. At least you should know it. There's a lot of people who have completely normal lipid panel, no other risk factors, but a really strong family history of premature heart disease. And we are finding quite commonly that elevated LP little a could be the responsible factor for this. Um, we right now don't have treatment for elevated LP
Right.
little a. Right now, what we do for people with elevated LP little a is we try to lower their LDL and get their LDL under 70. But I will say that in 2025, we're expecting a trial to roll out a drug that has specifically targeted LP little a and we know it lowers LP little a. What we need from our answers is, does it improve outcomes? We've been fooled in cardiology before, where we've had drugs that, for example, that raised the good cholesterol, HDL. They didn't save lives, and in fact, they potentially harmed lives. So those drugs we never heard of because they never came out. So we'll see what this trial in 25 comes out. We have another trial coming out in 2026, another novel drug, again, targeting LP little a. We might have therapies if you have elevated LP little a. And the reason I bring it up is it's super common. It happens,
Yeah.
actually, elevated LP little a occurs in 1 in 200 people. So it's really not rare. People used to talk about it as this rare thing. The more you check it, the more you realize like how many people are carrying this around. And to date, like I said, we don't have a targeted therapy aside from just lowering your LDL, but stay tuned. 2025 is going to prove to be a really interesting year. And maybe we'll have therapies for people.
So you mentioned a few minutes ago that sometimes what we eat can also increase our cholesterol, our LDL levels. And there's another fancy test out there, the cholesterol balance test, which Boston Heart does, that I've had done. And I think that's such a cool test because it shows you if you are something called a hyperabsorber or a hyper producer. And so that's whether or not your body absorbs too much dietary cholesterol, because our body really doesn't absorb a lot of dietary cholesterol like a normal body, right? Like it's something like less than 10 or 15%. But I actually absorb a lot. And so sometimes for people, having these tests done might be what they need to see in black and white in order to make an educated decision on how to proceed with possible therapy,
Yeah, I
drug therapy.
Yeah, definitely. I think that there is value in the test if the right people are interpreting them. I think
Right.
that one of the issues really is that people go and get these tests, and then it kind of makes me laugh sometimes because patients come with these tests and nobody, the person who ordered them for them, has not interpreted them to them, and they're not able to really even understand them. If their doctor doesn't even understand them, I don't know why they order them. I think that we being very logical about who you order tests in and why this might be part of the pathway of what's going on in an individual can really be helpful. But you have to be more than just I think there are people, doctors, labs. I think there's certain states here in the US that you can just go and get your blood work drawn yourself too without any order. And that also leads to people getting it and then not knowing what to do with it. So
Oh, absolutely. That's also why working with a health coach is also a very good idea, and having that person on your healthcare team as well to help guide you. Because for me, for example, I refer all of my midlife women clients to a preventive cardiologist. So that's who's ordering it, that's who's interpreting it, that's who they're having the conversation with, right? They're creating that relationship to really understand what's going on with their heart disease risk.
yeah, no, I think
Yeah.
that's a really good advice. And I think that, again, the more women are empowered too to understand their risk, the more they can ask the right questions.
Right.
I think in the past, I think medicine has very much been like, what the doctor does is the right thing, and that,
Yeah.
they must have done it, but they didn't tell me about it. I think we're of a different generation now where we want answers, we want explanations, we want to understand. And there's a lot of information for us now outside. And I'm not someone who hates Dr. Google. I don't think it's always right, but I think it's a starting point. And we also, as physicians, know what's out there. We know that there's some wrong information and there's some good
Yeah.
information out there. And we should what I encourage a lot of my medical colleagues is that we need to be the voice out there countering the misinformation, because there is misinformation out there. And the more that we can be out there educating the lay public, that means the more they'll understand correctly rather than wrongly.
So if there's a woman listening to us have this conversation right now and she's thinking, okay, my general practitioner only gets me a standard lipid test every year, and every year my cholesterol is sort of inching its way up a little bit higher, a little bit higher. At what point does the patient have the conversation with the doctor and say, hey, you know what, can I get a more comprehensive look and we assess my heart disease risk a little differently now instead of just watching this trend go up every single year?
Well, I think it would be important, of course, for somebody who has a very strong family history of heart disease and they have not identified why, you know, anything by them that might be genetically related. It might be useful to get a different assessment. But I think that just like everything, if we ask our doctors for something, chances are pretty high that you're going to get it. We don't want to withhold anything. If somebody's really convinced, even if I'm not convinced necessarily that someone needs a specific test, if it's a reasonable test, it's not going to harm them. I mean, blood work is just blood work. It's not going to harm them. You know, I will order it for them if it helps them feel more comfortable and confident with what we're doing and what their care pathway is. So I do encourage people to ask about things that they are, if there's like, I think I need a fancier lipid profile, okay, go get it. Again, I've told you my opinion on it because
Hmm.
I'm not somebody that orders it all the time. And so
Yeah.
it's not that I'm withholding it. I just don't think it's going to be useful. And for some people, I already know they're at high risk. And so that's the thing, is that's not going to change our plan.
Mm,
Nothing I see there is going to change a plan. I've already identified that you're high risk,
right.
you already need treatment, and nothing about other tests is going to change my decision. And sometimes it's helpful if somebody is not convinced even by the things I have that are saying, screaming out, you're at risk, come on, we got to treat you. Then sometimes we do other tests, whether that's blood work, whether that's things like coronary calcium scoring to really see. Sometimes seeing is believing. We see plaque. Patients
Right.
are much more willing to be ready to take medications. We have a lot of resistance. I'll tell you that being in the lipid field or the prevention field, I will say one of the most shocking things for my whole career is how many people don't want to take statins. Statins is the basis of prevention, at least for lipids, and why we reduce mortality from heart disease from the 80s to what it is now. A lot of that we can attribute to statin therapy. It's an amazing drug. And when people think that cardiologists are in the pockets of these statin makers, I just want to tell everyone statins are generic. We get nothing from saying it. We just know that they work effectively. And that's why we push them. We don't push them because of money. We push them to save lives. And I think that in people that need them, they are excellent medications. And there's a lot of people that are very resistant to taking statins for a lot of
Yep.
different reasons, including misinformation, but also personal experience that they've had side effects or they know
Yeah.
somebody with side effects. And so I think that, sometimes though, showing people that they already have plaque in their arteries helps me at least overcome that, because
Wow.
now they're seeing their own anatomy, they're seeing that disease is already there, and then they're like, okay, now I get it. And I think that that is another place like where testing can be useful to really help somebody understand both why this happened to them, but also helping them create a plan forward so that we can keep them around. I mean, the modern therapies are so amazing and I'm not somebody, again, I'm a preventive cardiologist, and anyone who knows me knows I run like a lunatic, I work out like a crazy person, I do all the lifestyle stuff. I'm the biggest believer in lifestyle, but in certain people, drugs are necessary. And so as much as I know we all want to do things naturally, but this is why we have modern medicine too, that we can use the combination.
Yeah, I'm so glad you brought up statins because like you're saying, there's so much pushback. And I will tell you that on social media, there are a lot of menopause experts
Oh
who
yeah.
are OBGYNs who are just telling all the women not to ever take a statin, that statins are not proven to work in women. And these are big doctors who have a big following, a big presence. And every time I hear them say this, I think to myself, oh my goodness, who's listening to this and thinking they're never going to go on statins? And so it really, I'm really glad that you're speaking to this because what they're saying is start taking estrogen early, which estrogen is amazing. I'm on all of the hormones and I'm on a statin and I'm on Zetia, right? So I've been on Zetia and a statin Zetia for 15 years now. I was very lucky to have a doctor early on who caught that hyperabsorber status in me. And when you're looking at the black and white numbers and you're looking at the scans, you can't help but think, okay, this is my reality. I have a family history of heart disease. Every single person besides my mother is dead from a heart disease, right? And so I have my kids who are all in their 20s, all started getting tested with more comprehensive labs to also assess their heart disease risk because we know that it starts in your 20s. Right. And so I'm really glad to hear you say this because this is why I really wanted to do this podcast with you to really speak to estrogen therapy. Is it there to be used as a preventive measure for heart disease? We know that it's used to prevent other things, right? And can help with a lot of other things. But as far as I know, and listening to you on your other podcasts, we don't have the data or the science to show that taking estrogen is going to help prevent heart disease.
Yeah.
But statins do. They help slow that process down.
Exactly. We have seen that. Absolutely. I know exactly, what you're talking about because this is one thing that we have had a lot of problem. I take care of a lot of women that are in their perimenopausal stages, and they are being told by some obstetrician gynecologists that they don't need statin therapy, that estrogen will, actually be a substitute. And some of them are stopping patients from taking their statin, and there is literally no evidence that estrogen will save your heart. And that's what you and I started with talking about at the
Right.
beginning of this program. It isn't just estrogen that is the cure-all. And yes, you can take estrogen. If you're going through menopause and you're having vasomotor symptoms, I will never stop anybody who, for your quality of life, for your sleep, for your sexual health,
Yeah.
it's okay to be on HRT as long as you don't have other risks that are obviously associated with HRT as well. We strongly encourage transdermal estrogen rather than oral estrogen to reduce some of the increased absorption because these days, again, we know we can get away with a small dose of estrogen. So I'm not anti-estrogen if you need it for symptoms, but there is people being given it even when they don't have symptoms. And that's perhaps the one that I don't fully understand. But it is not a substitute for statin therapy. It may even make your cholesterol look better. It may make your LDL anyway look better. It actually often will worsen your triglycerides, and we don't know the consequences of that. That was what we saw in the Women's Health Initiative, and that may be why also people on HRT actually had more cardiac events. We just don't know. These days, the HRT though levels are so low, the hormone
Right.
levels are low. And so I feel very comfortable if patients who are going through menopause need it. but it will never substitute or take away from whether they need a statin or not. And people should not confuse the two. And, this idea, I would just say this is the one thing about menopause. Menopause, we need to study so much more. We need to talk about it so much more, but we need to study it because there is people now preying on every menopausal woman. It just took people like Halle Berry to scream out that they're going through menopause that made everybody else, now it seems like it's cool and in vogue to now talk, which is a good thing. We should be able to more comfortably talk about our bodies and what's going on. But there is now people ready to prey on you because you're going through menopause. There's a whole marketing, like,
Oh,
understanding
yeah.
that women now going through menopause, they're often working women. They have their own independent money. It's a very different era. They're trying to find answers, because that's what our generation really is about, is trying to find answers to live healthier and live good lives. Um, but that also means that we are susceptible to people trying to sell us snake oil for what we're going through. So just be careful out there. Try to find reputable folks. I will say that there is many out there. I really love Jen Gutner. She's written a lot of great books, but she's very evidence-based. And I had the opportunity to talk with her, and we broke down sort of what we know about menopause recently. But look for a reliable source. People that are all or nothing, I think that though you might question why they are, and what is in it for them. There's people making their names solely by being a little bit controversial, and I don't think that's good either.
Do you have any tips for anyone listening right now on how to find a preventive cardiologist within their healthcare plan or at their local hospital? It was really hard for me to find one, and I absolutely found an awesome one. But they're not everywhere.
Yeah, they're not everywhere, but they are growing. If you can't find one in your community, I would encourage you to go to the American Society for Preventive Cardiology. We have a website, and on that, we do have lists of doctors in different
Right.
states. But if we don't list your state, write to us, because as the former president of that society, we'll find you someone. We now do have preventive cardiologists. Like I said, when I started with the American Society for Preventive Cardiology, there was almost like 200 members or something like that. After I finished my presidency, we were over 1,600 members. We have been growing like rapid fire, which is just amazing. We probably have someone nearby you. It's just probably you don't know. They don't always get labeled, even on their hospital or university website, as a preventive cardiologist. They get labeled as a cardiologist. And that's just to my point that they don't know what to do with us in the prevention world. But there are people out there willing to help you who love the idea. Anybody who's a preventive cardiologist, I call myself, for example, an early interventionalist, because in our field we have interventional cardiologists who throw in stents. I feel like if I get to you before, you'll never need them, you'll never need. And
Yeah.
that is my goal and that is my passion, but I have many colleagues across this country that have the exact same goal. We always talk about this, like how rewarding it is when we know inside that somebody, we're following patients 20, 30 years, they've had no cardiac events, and we know back in the day they would have, just based on the risks that they had. It doesn't, it's not the uh, gratification, maybe people who throw in a stent and see an artery open and they're like, oh, I saved your life. Probably the statin and the other medications that you're going to be on
Hmm.
the rest of their life might have saved their lives. So there's
Yeah.
a lot we can do. Your genetics also is not inevitable. A lot of people feel, well, like, my whole family, like you told us, everybody but your mom is not alive. Well, then, you know, genes don't dictate everything, because we do
Right.
know between medical modification, lifestyle modification, there is a lot that can be done despite even carrying a gene that says this person is going to have heart disease. We know it's not inevitable. We have data to support that. So do meet with preventive cardiologists, because we can help you.
Well, thank you so much. I'm going to absolutely put that in the show notes because that's going to be a huge golden nugget for the women listening to walk away with. Um, what a wonderful conversation with you. Thank you so much for your time and your expertise here. We didn't have time to dive into lifestyle interventions, and that is certainly what is on my mind as a health coach, helping to bridge that gap between maybe a poor diagnosis or a health goal and someone not being able to fit it into their life. Um, so thank you so much again. And I would like to also tell everybody, if you are not following Dr. Galati, follow her because you show all your workouts. You do work out like a mad woman. You've got that mirror thing that I see you do all the time. And it's just amazing. I love seeing doctors doing the hard work too, because it's really disheartening to go into your physician for an appointment and they're obese and they don't look well and they are tired and crabby, right? I want to see someone who's living proof that doing all the hard work is going to pay off.
Yeah, listen, we all carry genetics that sometimes are not good, and every day I feel like I am also just like you, trying to do everything I can do.
Yeah,
If I get heart disease, I get it, but I am gonna fight it every step of the way.
absolutely. Well, everyone, thank you so much for tuning in. Thank you again, Dr. Galati. And I'll put everything in the show notes. And everyone here is going to get on board with a preventive cardiologist in 2025. So thank you.
Bye bye.
Thank you for joining me. I hope you enjoyed the podcast. Lifestyle changes can be hard and overwhelming to make. By building your support team of functional medicine doctors, therapists, and health coaches, you can reach your optimal health goals. Be sure to check out my other podcasts. Until we meet again, stay healthy.